So the sharing today is about tubal ligation. So I just would like to share about a few techniques that usually use. So first we have the famous Polmeroy technique, whereby we ligate the ampular regions of the tube, and after that we're gonna cut it off. And in modified Polmeroy, usually we make it into a loop, tied it, and then the end result, and we separately ligate the proximal and the distal end. So the outcome will be something like this. So this is Polmeroy. So it's cut off. So the end result will be something like this. This is usually the usual technique used for BTL. So this is modified. Then we have, beside from Polmeroy, we have Irwing. So Irwing, usually they will plicate the proximal end to the myometrium or serous layer of the uterus. So plicate the distal end, the proximal end, and this is the distal end will be embedded into the broad ligament, the mesovarium. So something like this. So this will be the Irwing techniques. This is a very good method and very low failure rate. And further, we have something similar but called Uchida. So Uchida, basically the other way around. The proximal part will be embedded in the mesovarium, and the distal part will be freed out from the mesovarium. So usually the outcome will be something like this. So they embed the proximal end and distal end, it's make it free from the mesovarium. That's Uchida. Also have a very good, very low failure rate. Then we have something that we call Salphingectomy, whereby just cut off the tube, and there is no way that we can reverse these procedures. It's irreversible. And we have Fimbriectomy, whereby only remove the fimbral end. So this is usually have a very high failure rate. And also we have something that we call Falope ring. So basically it will turn out just like a Madeline method or the non-modified Polmeroy. How to sketch this? So yeah, it becomes something like this. So that's for the Falope ring. And we have what we call Flishie clip. Flishie clip. So basically just put a metal clip and even this clip can be seen from X-ray. Okay, so what is actually the what is the pearl methods to see whether this technique is good or bad? So we have what we call a pearl index, in which it will identify the rate of the failure in a woman in 100 women here. So we have, guess what, the lowest failure rate goes to implanon, and second, or is actually just similar to BTL, is IUD, and BTL the failure rate is about 0.3, And if you put Mirena, then you're gonna have somewhere 0.2 failure rate itself. So down here you have the COCs, you have the Depo-Provera is quite good actually, Depo-Provera and all. So if we have this per index means there are some of the methods that actually have a higher failure rate, while some methods actually contributes to lower failure rate. So how do we do tube reversal? Tube reversal. So we had a patient who had previously did bilateral tubal ligations because completed family, but unfortunately get separated or divorced from the husband and remarry, and now keen to get new child with a new husband. So what will be a tube reversal possibility for this patient? If we did fimbriectomy, then it is if we did a salphingectomy, then it's just irreversible. But if you do Flishie clip, Falope ring, Fimbriectomy, Uchida stacking, and Irwing, basically we can try to recanalize and reverse the tube ligations. So basically it's a canalizations of the tube. And some says there's a paper that quote that the prerequisite for the tubal reversal is actually to have 4 cm remnants of the tube. So sometimes we did a laparoscopy first, and then if it's possible, then we'll proceed with laparoscopy or can convert into laparotomy. Depends on the surgeon preference. So what is the successful rate for this? So the successful rate can be defined as 1, the successful of reversal. So some quoted to be 70 to 99% of successful reversal, but the successful pregnancy rate is a bit lower, around 50 to 60%. So now, what about when usually the patient get conceived, durations of conception after the reversal? So usually most quoted to be around 6 months for a spontaneous conception in purely tubal factor or in purely the tubal ligations. And then if you think of if we have recanalizations and there will be fibrosis, is there any risk of ectopic for this? Of course, there is a high risk of ectopic, but some quoted it's only to be around 1 to 7% of risk of ectopic pregnancy. And what about if we want to compare, if let's say the patient already had BTL done but keen for further for conception, then we can offer either IVF, right? So what about the IVF versus the tube reversal? So basically IVF, it's depend on the center, but we can quote around 15 to 30% of successful pregnancy rate, while tubal reversal is actually higher, 50 to 60% as quoted before. And so my point is that before we do any tubal ligations, in view of our change of the world, basically we have to think further because the way that our society acting is so much different from the previous generations. So we have to think twice before we do any tubal ligation. Thank you.